The Providence Journal invited 8 public officials to discuss race in Rhode Island, our series about the state's changing population, the gaps that have developed among the races, and the consequences for all of us. Their comments will help shape public policy and set the climate for how we treat each other. Doctor, thank you very much for participating.
Thank you for having me.
Okay. So let me start with the first question. What have you learned from the series? Did anything surprise you at all?
Not many surprises, but what I've appreciated from this series is the interest and investment that Rhode Island has in this crucial topic. It aligns perfectly with what our leading priorities are at the Department of Health and certainly the direction for the state with addressing social and environmental determinants of health, with eliminating disparities of health and promoting health equity, and then also ensuring access to care for all Rhode Islanders, including our vulnerable populations. So I absolutely welcome the opportunity to really put a spotlight on this and see what we as a state can do to help address this together.
Good. Rich, do you have a question?
Sure do. So as an African-American woman who moved here from out of state, what are your impressions of Rhode Island as a place for people of color to live, culturally, socially, and economically? And how divided do you think the state is compared to other places that you've lived?
Great. So originally being from New York City, I'm certainly familiar with naturally diverse communities. And being here in Rhode Island for 10 years now, I've appreciated, it's been a pleasant surprise of sorts for me. I'm definitely familiar with making the adjustment to a smaller city size, and certainly realize that there are families that go back for several years in Rhode Island, which is an appreciated history to acknowledge and celebrate, but have also appreciated the sections or the communities within Rhode Island that do represent some elements of diversity as well as economic diversity as well. Certainly there are areas for improvement, but I can say specifically from the healthcare standpoint, when I came here to do my fellowship in adult and pediatric infectious diseases, as I have shared with subsequent candidates who have come to Rhode Island to visit, it's something that you may not expect, but the communities of immigrants who are here, the refugee communities that are here, the Cape Verdean community that's very strong here, the Portuguese community, allows for a wonderful mixture. Certainly the African American community that has been here for years, this very strong Latino community, the number of languages that are spoken, being able to, in the healthcare system, have translation not only for Spanish, but also for Portuguese, for Creole, for some of our Hmong and Asian populations that are here. It's not something that I would have expected originally coming to this area, but I've appreciated that and certainly want to help make sure that those communities have as rich an experience in Rhode Island as Rhode Island has to offer, given the history that it's had as a state. So I've enjoyed that part, and I see a lot of opportunity for being an example and a model for other places to figure out how to embrace the diversity that's here, to celebrate it with opportunities such as this. Diversity oftentimes means strength. There's beauty in having a variety of perspectives and backgrounds to understand how to best handle a situation. Many people who have immigrated from other countries have overcome significant barriers and challenges in life, and those qualities from a life standpoint are things that can really help benefit our state.
Who's got the next question, Rich or Karen?
I did but I'm wondering, Karen, do you want to, since she mentioned the language issue, do you want to bring that up?
So I write
That seems like
about
perfect time.
immigration, immigrants, refugees, so I had a few questions there. So how, dealing with the question about language there. Language barriers present significant challenges in healthcare. Federal law requires certified and qualified interpreters for agencies receiving federal funds. How does the department meet this obligation? And have you personally experienced language and cultural barriers when you're treating patients, meeting people, and how do you overcome those?
Great questions. It's something that I'm passionate about, particularly in my previous world as a clinician. So to address your first question, it's absolutely a priority for us at the department to really help facilitate throughout the state a way to make sure that every language still allows someone to have the opportunity to communicate, whether it's sign language or a language other than English that's spoken, Braille even in terms of communicating appropriately. We have a big focus on providing culturally and linguistically appropriate services, so class, and making sure that not only healthcare facilities and clinics, but community-based organizations, public sector organizations and facilities all really have an understanding of the importance of addressing class, providing culturally and linguistically appropriate services, and then also know the best resources for doing it appropriately. There are a variety of components that are important to address with that. From my own experience as a provider, I've always valued the importance of being able to communicate adequately with the patient and have felt it to be a necessity to make sure that there is a medically appropriate service in place for caring for that patient. There are components in an interaction that a provider has with the patient that sometimes go beyond language. It's understanding the look in their eye, what fears they may have, what other questions they might have and not have had the ability to ask. And so it's always been important for me to make sure that the person has the opportunity to communicate even the nuances that are so crucial to be able to provide that care, to communicate it appropriately, rather than the assumption that someone, because they don't speak English, doesn't know or doesn't understand. I'm oftentimes telling myself this is someone's mother, this is someone's daughter or someone's aunt who was a matriarch in their family or a leader in their family, and just because our languages may differ, they have a tremendous amount to offer in their own health as well as in being able to support others. So having the ability to communicate adequately in all levels of healthcare or the services that are provided is crucial.
Linda, do you want to jump in?
Sure. It's wonderful to have a person of color in a leadership role, particularly around health. It's such a critical issue for everyone. But I know in Rhode Island, resources for all departments of government, resources are an issue. So given the role that you've said that the department has in terms of having the care of people of color and the disparities addressed, how do you allocate resources to really make a difference so that you have enough to make a difference in terms of the disparities that we see showing in every area of health?
Right. The way I like to look at the glass in terms of being half full is the resources are definitely an issue, but not a barrier that can't be overcome. It's actually a way to challenge us to figure out how to address the needs that aren't going to go away and that are there and need to be addressed in the most creative way possible so that we can have the greatest impact. for the resources, however limited they may be. There's also an opportunity that comes of that challenge to have us say, what are the assets, what are the strengths, the resiliency that exists in the communities where the resources are limited that we can also tap into. And it forces us to be able to see that communities are not in a situation where they can only take, but how can we look at it differently so that others can benefit from the strengths that exist within the communities. And that's not only strengths to be able to address their health once they have the tools that are needed to do that, but all elements of health, what the environment looks like, how safe it is, what their educational progress and attainment is, and ultimately employment and long-term economic stability. So the way that we are addressing that in looking at our second leading priority, which has two sides of the same coin, it's highlighting the disparities of health that exist, looking at the gaps that include racial and ethnic disparities, for sure, and then also look at additional disparities by sexual or gender orientation that exists with higher rates of specific diseases, or those who have disabilities might have higher rates of behavioral health challenges that we need to address and face together. So the flip side of addressing those disparities is promoting health equity, and that's the very exciting initiative of the health equity zones. The way I've described it is taking the siloed funding mechanisms that the federal government has given us in the past. We've spent actually years prior to this rolling out of the health equity zones, convincing our federal funders, let's do this differently, because we want to have a better impact so that we can address some of these disparities most effectively. We've been talking about these disparities for years. When are we going to do something differently to really address them? And so we have convinced our federal funders and the communities that we're serving, let's do this differently. We've taken the money that's there and have inserted it into the community in a structured way that allows for measuring our outcomes, which is a challenge to do, but a challenge we're up to doing, but also allows for sustainability and strengthening within a community. So our health equity zones takes money into one of the 11 zones who apply for funding through our request for proposal process, and says, as a zone, you need to establish a community collaborative that involves agencies and resources within your communities that vary from municipalities, school departments, healthcare facilities, the residents themselves, the businesses within those communities. Form a collaborative organization with one backbone agency who will interface directly with us, figure out what the disparities are specific to your area, and use not only the seed money that we're providing, but the resources that exist within that community to have action items and plans to implement to address those disparities specifically. So if there are areas where the language barrier is an issue, Providence as a city has done a great job being one of our health equity zones backbone agencies, and there's a focus on addressing transportation, making parks safer for those for the area that's there. There's another health equity zone that has a focus on substance abuse, and we celebrated South County within the last week and a half with the South County Hospital as a backbone agency, and there's been a tremendous amount of not only community collaboration, but work and change within the community, place-based, that has a focus on access to foods, which is what was celebrated, and doing a better job so that healthy foods are available, which helps our economy and helps kids do better in school and focus on education. So those are ways to creatively address with limited resources, but still get the impact that we need, including closing the gaps and disparities that exist.
Can I follow up on that? Can I just follow up again? So you just used the term limited resources, I think. You know, I'm looking at the front page of the Providence Journal today, $20 million for school buildings, $56 million in economic incentives for job creation. Rich tells us $2.7 million in federal funds for 11 health equity zones. Is that equitable financing? If you've got a priority issue here, closing the gaps, right? Tell me, does that seem equitable to you? And if it isn't, what do you need to do this?
Right, right. Well, our first start is to show that this works. This is another place where we can increase our investment over time.
Yeah.
We're one of the first states in the country that are really rolling out this type of health equity zone initiative, which is exciting because we're going to really make a difference. And we want to take this opportunity, work with our communities, build that sustainability that's going to be in place, and make it so that it's obvious that this is where we want to invest. We're already working with our hospitals. The Hospital Association for Rhode Island has been tremendous. Some that weren't already a part of our health equity zones are delving in, learning more about health equity zones so that the money that they are being required to focus back into their communities can help develop more health equity zones and really help build up from there. The ultimate goal isn't to make it so that each zone depends on federal funding to resource this. We want that to continue, but we want to also build within the communities, use the resources that we have. Our focus from the governor's standpoint and with her great leadership is to build economic stability for our state. So when we talk about food access, it's also about building our agriculture, supporting our farmers and our fishermen so that we are exporting more rather than importing, and can make it so that Rhode Island is a healthy and economically stable state that people want to come to. And that's a way to really continue to build it. And over time, the money will start to flow to that because people will see the return on investment that makes it worth it.
Doctor, with due respect, I didn't hear a number, okay? So 2.7, whether it's local community resources, whether it's federal money, whether it's state money, what are you talking about to make this work, to close the gaps?
So are you saying is 2.7 enough, or?
I think I'm hearing you saying 2% is not enough, it's just a start, it's a pilot program.
Right.
So if the goal is to close the health equity gaps using this private model, which, where you have resources coming from community resources, state resources, federal, what's it take to get this done? What's the number? What resources do you need?
There isn't a set amount. We need to start seeing the improvement, and it will continue to expand from there.
Yeah.
I love the focus, and the Secretary does great at reminding it's not always about just pouring in money and resources. It's also, how can we do this more creatively? We have some resources in places that might not be financial only or attached just to a dollar, but what can we do differently with that? We'll certainly always need funding and resources, but I want the focus to be that it's not we are depending on a specific amount. It's let's get money in there, let's get the seed going, and then have the community have the resources grow from there to be able to sustain it.
Rich, right.
Doc-
Go ahead.
Doctor, what do you anticipate, what's the timetable? When can we expect to see some of the first results from the equity zones?
Yep.
So that we can actually use it and chart the progress so that when it's time to look at refunding, there's the documentation there.
Absolutely. It's a crucial component to this process. So this is about a 4-year grant. We're 6 months into the process. We're in the early phases. Some communities are further along than others because some already had community assessments that were in place that we're building on, and other communities, now that they're forming this collaborative, has to say, okay, what are the biggest gaps, or what are the numbers? People have determined where they want to focus, and now getting a better understanding of the baseline of the numbers so that we can track the metrics going forward from there. A big national push, also driven by us, having met with our federal funders recently, is figuring out ways to show that return on investment. We have to have metrics, and people are used to metrics specific to the diseases, which are important, getting diabetes rates down and better controlled, addressing the obesity epidemic, certainly stopping the overdose epidemic that exists. We've had 1,000 deaths in the last 5 years. That's preventable. We have to do something about it. But now also being able to show this funding, this new way of doing things is not only going to help health as in reference to those diseases, but also address health in the broader term, what the communities look like, how safe is it for you to now be able to walk through your community instead of hopping in the car to drive, what is your educational system, how supportive is it of you being successful throughout the rest of your career, how many parents have full-time jobs in houses where we have young kids. Currently in Rhode Island, 21%, going into 22% of children are living in poverty. That has generational consequences. If we can change that, improve their education, get them out of the poverty mindset, establish some hope for children to move forward, you're changing generations of outcomes. I've appreciated hearing the governor's story, which is powerful because of who's saying it, of her father being the first one who was educated, and now you see how tremendously successful her generation has been, and certainly that's going to continue. Those are the type of easy changes that we can make to show the return on investment. But the next thing we have to do is measure it and make it clear. And that's been a goal over time. As communities are developing their health assessments, we're establishing that as baselines and want to continue to follow out from there. The second way to answer what you're saying also is, over the last several months at the Department of Health, we've helped establish population health goals. We've appreciated the charge at the state level to say, where do we want to focus? So we've taken our 3 leading priorities, linked it to 5 strategies for addressing it. That looks at healthy living, it looks at making sure we have access to food and water and healthy environments, also addressing emergent threats and diseases that are out there, such as our substance abuse and overdose epidemic, and using data in a way that is most effective. And we have population health goals with each of those strategies and metrics to follow. And we want to have that as a template for us as a state to focus on over the next 5 years and to clearly follow out and see the improvements. That's an absolute necessity.
So just to sort of try to pin you down to a time frame, if we were to say, okay, we're 6 months, did you say, into the 4-year grant, then at this time next year, it's time to say, okay, where are we publicly? So I'm sure you're looking at this on a regular basis internally, but to let the community
Absolutely.
know where things stand.
Yeah, and so my answer to that was a part of laying out our population health goals. We have it aligned with metrics from Healthy People 2020, so that's 5 years from now. But what we'd like to do is show the yearly increase going to our 5-year mark. And we are looking to see exponential improvements. It's going to be a steady and slow process, but we want to make those metrics clear and available to the public from day one and follow them out together, seeing how the health equity zones contribute to it. We have a great relationship with our community health centers. We're doing a phenomenal job addressing the needs in the communities. Our primary care providers are partners throughout the state. I met with our primary care provider advisory committee this morning, who's been committed for years on behalf of primary care providers, and all of us together, as well as the communities themselves, can monitor this, starting from now and continuing to track going forward.
Great, thanks.
Rich, should I keep going?
Sure. So some of these, the whole idea of disparities, I think sometimes can get pretty abstract for some people. What are some of the examples that you like to focus on, and which ones do you think are really the most important?
So disparities examples that exist, as I mentioned, include race and ethnicity, particularly when we talk about healthcare outcomes or disease-related outcomes. We definitely know that some of our racial and ethnic communities have higher rates of diabetes, of asthma, of cancer, That's true for African Americans, it's true for Native Americans that we don't always acknowledge and highlight, but there are high rates of diseases there that we need to acknowledge, and Latino communities as well as immigrants and many others. So addressing diseases related to race and ethnicity is key. An expansion beyond that is looking at disparities based on gender. Our overdose epidemic significantly, disproportionately affects men compared to women. Addressing that is crucial. Disparities by age, if we look at environmental safety issues, certainly our seniors, fall prevention is crucial. And with our youth and children having safe playgrounds, parks, addressing the lead exposure that exists because of the significant long-term consequences of lead exposure. Additional disparities include those based on education. There's data that reflects the concept that those who have not had a high school degree have a 7-year or so difference in life expectancy outcome compared to those who have graduated from college. So those are disparities also that we need to highlight. And I mentioned earlier disparities by sexual and gender orientation. Our men who have sex with men communities as well as our transgender communities have much higher rates of HIV and sometimes syphilis than others. So to be able to tell you that one disparity is more important than the other certainly is not an easy thing to do because of the comprehensive way that we have to look at disparities. Incarceration is yet another within itself. Within each of those communities, there are significant concerns that have to be addressed. So instead of focusing on one more than the other, it's really looking at how can we close these gaps that exist in our outcomes.
But aren't the racial and ethnic disparities, don't they cut across all of the other categories and rise to the top in terms of the greatest area of concern?
The racial and ethnic disparities definitely, particularly in reference to healthcare and disease outcomes, there's definitely data that shows when you adjust for many of the other components, the racial and ethnic components continue to exist and need to be addressed. So that is something that is certainly highlighted across the board and incorporated into our leading priorities as a department.
Karen.
Okay, so in addressing these inequities, has anything very unexpected emerged that does not fall within the rubric of your plan?
Let's see, I'm trying to, I think our goal has been to be as comprehensive as we can so that we do address all elements of our plan with it. And what it highlights for me is that the Department of Health, the Rhode Island Department of Health, cannot address these disparities alone. That is crucial. Coordination with our state agencies, my co-chair with me on the Governor's Overdose Task Force, Director Maria Montanaro, who's the head of Department for Behavioral Healthcare, Developmental Disabilities, Behavioral Healthcare, Developmental Disabilities, and Hospitals. We are continually engaging in how we can address the overdose epidemic, how we can better support those with behavioral health and other concerns. Our Department of Children, Youth, and Families, DCYF, was led by Genia McDonald, absolutely requires collaboration and coordination in order for us to address it. And under both the Secretary's leadership as well as the Governor's leadership, it's what I'm really enjoying about this role, is we really have the opportunity to address inefficiencies and really strengthen coordination so that the patient who as a whole person doesn't break up themselves based on the agency that addresses their specific need, so that the patient has a better experience both in the healthcare system as well as navigating the system at the community level. So less so than being outside of the rubric of the plan, it's more so than, for me, appreciating, which has been known, but also now being in the role to be able to do something about it, the necessity of having collaboration, not only with the state agencies, but also with our community agencies who have been passionate about this, who have been stakeholders, the media, a crucial component, so really being able to leverage resources in a way that can make a difference better for closing these disparities gaps.
Rich, you have the next one?
Sure. So I know you mentioned some of this, the project involving the health equity zones is in some way cutting edge. Can you point to, or are you inspired by work that's taking place elsewhere in the country, in a particular city, Harlem, for example, where you see what they're doing and you say, I want to do that here, and I really wish I could make that happen?
Right. That's a great question. I've enjoyed that aspect as well, collaborating with or meeting and learning from my counterparts in not only neighboring states within the region, but also states throughout the country. So our health officials organization, the Association for State and Territorial Health Officials, ASTO, has an excellent infrastructure for helping us learn across states how we can do a better job in some areas where we've had more experience, such as our immunization rates and the progress that we've had. Rhode Island is one of the #1 states in the country, certainly for immunizing our children. Being able to share with other states why we're so successful with that and what has worked so well. And then learning from other states. Minnesota stands out to me. The newest president of ASTO is the Minnesota Department of Health Director, and they have done great work with a focus on health equity at the state level and overcoming some of the barriers that might exist in terms of reimbursement or how we can engage better with the communities and really coordinating efforts in a way that makes a difference. Our previous ASTO president, so immediate past president, Jewel Mullen, is the Connecticut Department of Health Director, and has done a phenomenal job bringing attention to healthy aging and all of the components that go into that. We know that by 2050, a significant proportion of our population is going to be of the baby boomer generation. And what's the best way that we can benefit from that? Making sure that our economy is boosted, making sure that resources are in place, and a key that I see that we can contribute to that is making sure that the population is healthy and providing the community resources and the support that's needed to ensure that that happens and that people aren't institutionalized or hospitalized in ways that could have been prevented. So some of those lessons and achievements that other states have done are what I've enjoyed learning from, and then also sharing some of the great things that Rhode Island has achieved as well. Other states have been very interested in our health equity zones progress.
Linda?
What role do you see the private insurers playing in supporting your efforts?
Private insurers have been crucial partners, and I applaud private insurers because they have been a part of this going forward. Specifically for the Health Equity Zones Initiative, I certainly welcome insurers who have areas, whether they're based in a specific community where the health equity zone is, or they have funds that need to focus on a particular community. The opportunities are there to partner with health insurers. We welcome that, and I'll continue to engage with them. I also celebrate where our insurers have supported. Part of why we do such a great job with our immunization rates are because health insurers help make sure that we have state-supplied vaccines available. That's something to be celebrated. It's a partnership that's there. We also have a loan repayment program for primary care providers across the board and across disciplines. Our health insurers have already done a great job contributing to that. So having the infrastructure in place to establish and strengthen that partnership is the crucial first step, and then making sure that the opportunities are there. I like to find the balance because insurers are a key contributor, but I hesitate to put everything on insurers because oftentimes that then means premiums go up and the people who need the insurance end up having to pay more. So we want to find a balance so that insurers can contribute, but we have additional resources within communities that can sustain the work that needs to be done.
Sure. So the spirit and cultural beliefs of some immigrant and refugee populations are at odds with Western medicine. I'm thinking of a famous 1990 federal court case in Rhode Island involving the autopsy of a Hmong man over his family's objections. Is cross-cultural medicine on the health department's radar, and if so, how?
Excellent. So cross-cultural medicine would be something that we support from the health department's standpoint in terms of each of our leading priorities, essentially. When we talk about addressing social and environmental determinants of health, it's making sure that communities have access to the foods that are needed, and that includes the cultural foods that exist that people are used to and really enjoy and help promote healthy living. When we talk about addressing disparities, it certainly includes those that are experienced across cultures and making sure that we have culturally and linguistically appropriate services available so that we can communicate appropriately with people, because the goal is to make sure that everyone is healthy and doing it in a way that resonates with the individual based on their own cultural needs and requirements. And then our third leading priority of ensuring access to quality health services includes our vulnerable populations. And if there are language barriers or differences in cultures and understandings, a population can become vulnerable because of its difference with Western culture. And a key would be to make sure that the services that are crucial to their health are as available and supported in a way that works best for those communities. And a lot of times there isn't a rule book that you have to play. You work on an individual basis with individual communities. When you see one community, you see one community. And being able to support what's needed for the individual community to be as healthy as they can in a way that's equitable and allows to return on investment that's beneficial, because some of these communities have resources that can contribute within themselves as well. That's the model that we'd like to promote.
So along those lines, refugees by definition are escaping traumatic situations, and many people within Rhode Island's refugee populations experience long-term post-traumatic stress. So how do you address that across the population?
That's a crucial component, and we have a strong refugee health program as a priority in Rhode Island. We currently fund 2 Rhode Island resettlement agencies that have a focus and understanding on the challenges that are unique to refugee communities. We also help make sure that all refugees get a health assessment within 30 days of their arrival in Rhode Island, and that health assessment will certainly include the behavioral health component that people who are familiar with the challenges that refugees face is addressed and is necessary to do. And something that we are doing currently as well is a community health needs assessment with a focus on refugees, so that we can have a better understanding and really make it more available and raise awareness for providers across the board that as refugees resettle and get acclimated to this new environment, that the support is there to help address and account for the very real challenges that have been faced in the past in their home countries or that continue to occur here. So addressing that together as a state is an important thing.
Which programs do you fund? You mentioned
The two resettlement agencies are the Diocese of Providence and Dorcas International.
Rich, do you want to?
Sure. So, how aware are you of being one of the few top officials in state government who is a person of color, and how does it make you feel? And do you think more should be done to add diversity to the top levels of government in Rhode Island?
Well, I am aware, just by living, of being one of those top officials. It makes me feel very proud. I'm honored to serve in that role, and I appreciate the leadership of the governor and others who supported that opportunity. And like the governor, I also fully support diversity across the board in leadership levels, as we talked about, and I love to say diversity brings strength. You have a variety of backgrounds, variety of ideas, experiences that adds new ways of accomplishing things. We're in an age where we have to be creative, we have to be innovative, and the more diverse perspectives we have, the better we are at being able to achieve that effectively. And doing it in a way that supports communities that might not have a voice to say what's important or what's needed for them to thrive. So I look forward to more diversity. I appreciate this as a focus on it, and continuing to promote it at the leadership level is something that I'm confident will continue to go in that direction with.
Does it feel like we're a little bit behind and that we have a long way to go?
We in Rhode Island or
Yes.
as a nation?
Rhode
There's always room for improvement. So whether or not we are behind is oftentimes interesting. One of the things that I loved experiencing at our ASTO annual meeting that I referenced earlier was meeting a Surgeon General, Jocelyn, and remembering her last name, but was Bill Clinton's Surgeon General in the late, in the mid-90s. And we certainly need more diversity. And someone may have said we'd accomplished what we needed then, but then we went many years without having leadership reflect that. So less so than being behind versus caught up. It's more of an importance to focus on just having sustainable, continued energy and understanding and acknowledgement of this as being a priority.
And can I just follow up on Richard, just to close the loop on that, because our series has been a lot more than just issues. It's about how we live with each other. I think the general question we've asked everybody is, what should be the role of a state official to improve race relations? How outspoken should you be?
I think it should be a natural component of what we discuss. It's not always an easy thing to highlight, but it's an everyday experience. So it should accompany, I would say naturally, all that we are talking about addressing. When we talk about closing gaps, It's clearly understanding that race and ethnicity are a crucial component of that. And then also understanding that there are additional components that even if you adjust for them, race still is there, but it doesn't discount the other components that are there as well that people are impacted by across the board. So rather than being outspoken versus not, it needs to be something that we are all comfortable acknowledging and discussing because it is a very real experience.
We have time for a couple more. Go ahead, Linda.
Have you prioritized diversity of the workforce within your agency?
Yes. It's been something that has been a focus. I've appreciated meeting with the head of diversity for the state, Cheryl Burrell, who's doing a great job leading that office under Director DeBase's leadership, and has data on how each of the agencies are doing and is providing support and resources for helping each agency do a better job with improving diversity at all levels, managerial as well as frontline staff. So we are definitely engaged in seeing ways to improve that because we know that the qualifications are there across the board. We know the strength that's brought in when we have that as a focus. It's really just a matter of knowing that energy has to be committed to seeing that that's important to address.
Karen, do you have one left, or Rich?
Yes, so,
One each, Karen, and then Tricia.
okay, so have you received complaints of a lag in ambulance times in underserved communities, and if so, what do you do about that?
I haven't personally heard of those complaints specific to the Department of Health, but we have a very strong EMS program led by Jason Rhodes within the department that has a focus looking through the lens that I've described of health equity and social and environmental determinants of health and ensuring access for all, including our vulnerable. So it's absolutely on the radar to make sure that if there are communities that are seeing a gap or a disparity in ambulance response times in certain communities as opposed to others, that's something that we would want to address and have it be important to make it so that experience isn't there. We're seeing tremendous opportunities with our EMS partners on how we can engage in communities better, particularly when we talk about addressing the healthcare system differently and more creative. Our EMS partners really give an opportunity to say if there's something that can be handled within the community where there are resources and EMS can help facilitate that instead of bringing folks to hospital and the healthcare facility when they may not be necessary. It's a tremendous opportunity both for that community as well as the EMS organization to allow for preventative services, save money, and make it a better experience for the communities.
Excuse me. So if finances weren't an issue, if politics weren't an issue, and John was to hand over his magic wand to you, what one thing would you like to do with that kind of free card to do exactly what you want to do to address health disparities?
That's a great question. I would like every community to have this health equity zones type of focus so that there are resources in place. I'm a big believer in understanding the assets and the strengths, the resiliency that already exists and building off of that. I know that's not the answer to everything, but making sure that that's a part of the solution and doing it in a way that's sustainable. So it's so exciting to me with the health equity zones to see how law enforcement and healthcare facilities and school departments and businesses and residents are sitting at a table, communicating with each other, focused on specific gaps and disparities that exist to underserved populations, to vulnerable populations, and saying, what are things that you can do, what can I do so we can address that better? If every community can have that and build it out from the community, because each area knows what their needs are and what's important for them, and we could support that as a state, I think that that would be tremendous.
Dr., just to finish up, what are we missing in our series? What do you ask, and why aren't they looking at that?
One of the things we were discussing, and it's been a learning process for me as well, is our Native American population. 54% of Native American children are living in poverty, and it's often such a crucial community group that is overlooked. This is Native American land to start, and to the extent that we can support our Native American communities, myself included, doing a better job on highlighting and focusing on what the needs are, I think would be invaluable.
That's just about an hour. Thank you very, very much. We'd like you to come back sometime.
Great.
Thanks again.
Thank you so much.